I want you to look at this EKG and tell me what the diagnosis is. What do you use to call right bundle? What duration do you need for incomplete and complete? Based on the ACC criteria, in order to define complete bundle branch block, you need to be over 120 milliseconds. And incomplete bundle branch block, it is between 110 and 119 milliseconds. Less than 110 millisecond is not a bundle branch block. Same to define non-specific intraventricular conduction delay. You need a QRS over 110 milliseconds without a specific feature for right or left bundle branch block. So here, actually, I don't think we have delayed conduction. It's two, maybe barely 2.5 boxes. So it's less than 110 milliseconds. So there is no bundle branch block. So what you have on this EKG, you have right axis deviation, QRS negative in 1 and upright in AVF. And you have an upright R in V1 that is larger than S. Actually, there is monophasic R here. So the diagnosis is straightforward. This is right ventricular hypertrophy. And this patient's QRS is less than 110 milliseconds. So you don't have that dilemma of trying to diagnose RVH in the setting of right bundle branch block, which I'm going to explain shortly. So this patient has RVH, and this is how RVH is defined, is right axis deviation more than plus 90 degree, or sometimes a little less, but close to plus 90 degree, you know, maybe plus 80 degrees. And so you need right axis deviation. Unlike LVH, you don't need left axis deviation. And actually with LVH, you tend to get a leftward axis. You don't usually get full-blown left axis less than minus 30 degrees. Actually, with LVH, if you have a full-blown left axis, it's usually something else associated with it. It's either left bundle branch block or more commonly left anterior fascicular block when it's a full-blown less than minus 30 degree axis. Okay? In RVH, on the other hand, it's mandatory to have right axis deviation to define RVH or close to right axis. And on top of that, you need big R wave in the right lead V1. Most importantly, R bigger than S, or if not bigger than S, more than 7 millimeters. Another criterion, and here are some morphologies. You can have R bigger than S or more than 7 millimeter in lead V1, or you can have the whole QRS is small with a tiny S less than 2 millimeter. Another feature is big S, bigger than R wave in lead V6. This feature is less specific and I don't like it too much, because this may be seen in anything that turns the heart axis posteriorly. You may see it with LVH, with left anterior fascicular block, in which cases, however, the axis is not right. You may see it with lung disease that pushes the heart posteriorly. And in lung disease, you may have right axis deviation and S bigger than R in lead V6. That nonetheless does not imply RVH. So for those reasons, S bigger than R in V6 is not specific for RVH. So those are the most important criteria in RVH. And the reason we get those criteria in RVH is that in RVH, the heart is extending down in the frontal plane and it's extending anteriorly. The depolarization axis is extending anteriorly in the horizontal plane. Therefore, those anterior forces are pronounced in V1, V2. The anterior forces cause big positivity in the right leads, V1, V2, and they cause big negativity in the left leads, V5, V6, and 1 AVL. And the big positivity could be big R, but sometimes it's just a tinier S than usual, like I mentioned, less than 2 millimeters. And sometimes you get an RSR prime pattern, which I will explain. This is another EKG. What's the diagnosis here? This is right axis deviation with an RSR prime pattern in lead V1 less than 110 milliseconds with an R prime bigger than S. That is indicative of RVH. The same way R bigger than S indicates RVH when you have a standard QRS pattern. R prime bigger than S when you have RSR prime pattern is indicative of RVH, particularly when the QRS is less than 110, sometimes when it's 110 to 120 or more than 120 as well. So this is RVH, no right bundle branch block and no incomplete right bundle branch block. Now, I want to explain that more. It's easy to diagnose RVH when the QRS is less than 110 milliseconds. It's more difficult and less specific and less sensitive to diagnose RVH when your QRS is wider and when you have right bundle branch block. So I want to elaborate on this somewhat complex issue, the overlap between RVH and right bundle branch block. So RSR prime in V1 is normal if the QRS is less than 110 millisecond and the axis is normal and S bigger than R and R prime. It's a common normal variant. I try not to even comment on it when I read the EKG. RSR prime in V1 is a right bundle branch block, whether incomplete or complete, if it is more than 110 milliseconds, in which case R prime, it's not only wide, it's also R prime is definitely taller than R and frequently taller than S. So that indicates pathology, width, and a change in the height parameters. RSR prime is RVH if QRS is less than 110 milliseconds, but you have R prime bigger than S with right axis deviation. So this is a pure RVH if QRS less than 110 with this R prime more than S and right axis, as in this patient. Now, RSR prime could be combined RVH with right bundle branch block if QRS is over 110 milliseconds and R prime bigger than S with the right axis. An important idea here you need to recognize: right bundle branch block does not cause by itself right axis deviation. So when you have right axis deviation in conjunction with right bundle branch block, it's something else on top of it. And that's usually your hint to RVH. Right bundle branch block with R prime bigger than S and right axis is very possibly RVH. Now, I didn't say it's definitely RVH associated with it. Why? Because what's the other option? It's left posterior fascicular block. So a right bundle branch block with right axis could be left posterior fascicular block, or more commonly RVH, because left posterior fascicular block is an uncommon conduction disease. It's the least common conduction disease. Further suggestion of RVH will be R prime bigger than S, or R prime, as I will explain, more than 10 to 15 millimeters. And the reason right bundle branch block doesn't cause right axis is that always we define a frontal axis by looking at the first two boxes of the QRS. We don't integrate the vector of the whole QRS. QRS could be 150 milliseconds, but we're not integrating all the forces. By definition, a frontal axis is defined by looking at the forces of the first 80 milliseconds. So in right bundle, you may have area under the curve of this S bigger than the area under the curve of this narrow R. So that will make the axis potentially rightward if you integrate all of the forces under the curve. But by convention, the frontal axis is defined by using the first 80 milliseconds. So we're going to truncate that S wave, and you'll end up with a normal axis in right bundle branch block. And how to diagnose RVH when there is right bundle branch block? Know the following idea: most incomplete and complete right bundle branch block are benign and not related to RVH. And in a lot of Nordic studies, they are not associated with impaired long-term cardiac prognosis. On the flip side, most RVH from volume overload has some degree of RSR prime or incomplete or even complete right bundle branch block. All this being due to the sluggish spread of depolarization across a dilated right ventricle. So incomplete right bundle branch block may be worrisome for RVH if it has these features: R prime more than S and more than 10 plus right axis. Incomplete right bundle branch block, RVH diagnosis is less specific. Compared to, again, the left side I explained yesterday, when you have left bundle branch block, you inherently assume there is LVH in most of the cases. Most often, left bundle branch block is not pure conduction disease. It is conduction disease with some myocardial disease, most commonly LVH. Could be more dilated cardiomyopathy and systolic dysfunction. A right bundle branch block is different, and that's why it's hard to make the RVH diagnosis with right bundle branch block, simply because right bundle branch block is most often a pure conduction disease. So unlike left bundle branch block, which is often related to intrinsic LV disease and LVH, often hypertensive disease, most right bundle branch block are not RVH. They are just pure conduction disease, and it's important to try to diagnose whether RVH is present or not. So look at this EKG and tell me here what's the diagnosis. This is wide. This is very wide. It is 120 and more than 120. When we measure the QRS width, always pick the lead where it's widest. You can see in V5, V6, it's quite wide, that QRS. So it is complete right bundle branch block. The question, is there RVH? What other findings you have here? This patient has sinus tachycardia. He has a right bundle branch block with a QRS over 120 milliseconds. And he has right axis deviation. So you have right bundle branch block with right axis deviation. It's either right bundle branch block plus left posterior fascicular block or plus RVH. Supportive feature of RVH on top of right axis will be R prime more than 10, or better yet, more than 15 millimeters. But even that is not specific. So you can have right bundle with a big R prime and no RVH, purely due to conduction disease. Conversely, you can have RVH with right bundle and R prime less than 10 or 15. So again, you lose sensitivity and specificity in right bundle branch block. Most often when I see right axis, I assume it is RVH in conjunction with right bundle branch block, but I take always the clinical picture in context. This particular patient with his sinus tachycardia, this is not just conduction disease. He was coming with dyspnea and he was diagnosed with PE. He did have actually RVH on his echo that this criterion would have missed. To diagnose right atrial enlargement, you need to have the height of the P wave in lead 2 more than 2.5 millimeters. And it is here around that number. That could suggest right atrial enlargement. Or alternatively, to call it right atrial enlargement, the positivity of P wave in lead V1 would be over 1.5 millimeters. As you may see here, the positivity in V1 becomes over 1.5 millimeters, or the height of P wave in lead 2 would be over 2.5 millimeters. Either one of those. He doesn't have the V1 criterion here. The catch, when you have sinus tachycardia, the P wave height increases, so much so that the criteria for right atrial enlargement become less specific. So having a P wave taller than 2.5 millimeters or barely 2.5 millimeters in somebody with sinus tachycardia is less specific for right atrial enlargement than regular sinus rhythm. This is another EKG. What's the diagnosis? Always start by analyzing the QRS width before you jump to the height. It's two small boxes. Look in any lead. It's not more than 2.5 small boxes. So we have right axis deviation. We have a QRS that's about 100 to 110 milliseconds. There is no right bundle branch block here. And importantly, you have that what I call the QR pattern. You see QR pattern in lead V1. This is definite RVH. There is no other option here. This is not left posterior fascicular block. Left posterior fascicular block gives you right axis deviation, but doesn't give you any abnormality in the precordial leads. You have no reason to have RSR prime or QR or big R unless you have associated right bundle branch block. But this being narrow, this is a QR pattern of RVH with right axis deviation. And the reason I'm showing this is that you need to recognize that specific QR pattern of RVH, which I will explain. Another finding on this EKG is you do have definitely right atrial enlargement. The P wave in lead 2, it's stall over 2.5 millimeters in height. It doesn't quite make the cutoff in lead V1 where the positivity should be more than 1.5 millimeters. You do have a feature of left atrial enlargement. It's deeper than 1 millimeter and wide 1 millimeter. So you have biatrial enlargement. You also have something else suggestive of left atrial enlargement, that prolonged, somewhat notch P in lead. Usually you would see it in lead 2, but you see it here in lead 1. But the more important diagnosis for me is RVH with a QR pattern. And here is why I want you to know that. RVH, I mentioned you may have RSR prime pattern. And I mentioned the RSR prime pattern is suggestive of volume overload. You lose some specificity the wider the RSR prime is, but regardless, it does suggest a volume overload type of RVH if it is RVH. On the other hand, when you have a QR pattern, as in here, or if you have monophasic R, as in this one, it's a monophasic R, notched, but monophasic. There is no S. It's a notched R. So when you have a QR or monophasic R instead of RS or RSR prime pattern, this is suggestive of severely increased right ventricular pressure, severe pressure overload type of RVH. And it usually suggests that the RV systolic pressure is equal or higher than the systemic pressure. So you frequently see that in pulmonic stenosis or in severe pulmonary hypertension. So be familiar with that QR pattern or monophasic R without widened QRS, which is suggestive of pressure overload. The widened QRS RSR prime is suggestive of volume overload simply because the RV is dilated in volume overload, and therefore the electrical depolarization takes longer to spread throughout that right ventricle, and you get that QRS prolongation and RSR prime. RVH, like LVH, may lead to secondary STT abnormalities. So, and those secondary STT abnormalities will look in opposite direction to the QRS. So in leads V1 through V3, you will have ST depression opposite to the QRS. You tend to get more T inversion than ST depression with RVH, just because usually the RV mass is smaller than the LV mass. So we get more strain pattern, more ST depression with LVH than you do get with RVH. But you definitely can get straight pattern with RVH depending on the severity of the RVH. And it will be ST depression with T inversion. Again, more commonly T inversion than ST depression and more pronounced T inversion than ST depression. But regardless, you can get both. And this is what you're having here. You're having here RVH with a strain pattern. This is a patient with very severe pulmonary hypertension and RV pressure overload, and you're getting those secondary STT abnormality. So left bundle branch block inherently causes opposite change, STT elevation, and depressions. LVH may cause the same discordant ST changes as well. RVH and right bundle branch block may lead to ST depression and T inversion, but they do not lead to ST elevation. And that's a major difference between the right-sided issues versus the left-sided issues. One difference is that the STT depression you get with the right-sided issues is usually not as pronounced as the one you get with the left-sided issues. Although it can be pronounced, it's less commonly pronounced. And number two, you do not get ST elevation with the right-sided issues. So ST elevation with RVH or right bundle branch block, even if it looks discordant, it's always abnormal and suggestive of a primary process, such as an MI. I showed this EKG earlier, and I just want to explain this idea. Lung disease pattern is different from right ventricular hypertrophy. You can have lung disease pattern without right ventricular hypertrophy. And what it means, you have a lot of chest air and increased size chest cavity, which will press the heart and make it more vertical in a frontal plane and push it posteriorly in a horizontal plane. So this is what lung disease leads to. It will lead to a vertical heart axis in the frontal plane, and it will cause posterior heart shift, meaning deep S wave throughout all of the precordial leads and poor precordial R wave progression. So we'll have small r, big S throughout all the precordial leads because the heart is pushed posteriorly. So the right axis, the S bigger than R in V6, can mimic RVH. So by EKG, it can mimic RVH, but it is different than RVH, and there are specific criteria to diagnose RVH in context. So this chronic lung disease pattern may simulate RVH. True RVH in conjunction with lung disease requires additional features. And I'll explain that. So whenever you have an EKG like this, you have right axis, but you also have that small r, big S throughout most of the precordial leads, with an overall QRS that is not large and may even fill the features of low voltage, you're thinking lung disease. So right axis, small r, big S throughout the precordial leads with a total QRS height that is not large. This is very suggestive of lung disease. To diagnose RVH on top of that, you need additional features, and the additional features are those. You want large R or small S in V1. So it's not just that you have deep S throughout. Well, maybe in V1, the R is bigger than the S, or that S that is bigger than R is still very small, like the whole complex is small and S is less than 2 millimeters. Or you will have the strain pattern that will suggest RVH, T inversion in V1, V2. So that will suggest RVH in conjunction with lung disease. Or you will have an RSR prime pattern that will suggest RVH on top of lung disease, including RSR prime less than 110 milliseconds. Also, P pulmonale is less helpful because with lung disease, as the heart becomes more vertical, the atria plane of depolarization becomes more vertical, so you can get a high P wave in lead 2. So P pulmonale may be seen with lung disease even without RVH or right atrial enlargement. So P pulmonale becomes less specific for RVH or R atrial enlargement. So you understand that pattern? I want you to know that when I was a fellow, I used to get confused. Is lung disease pattern, RVH, there is overlap. That's why I tried to explain to you also RVH and right bundle branch block overlap. There's a lot of overlap between those pathologies. So I mentioned that the lung disease pattern may simulate RVH. I mentioned the criteria for that. Also, as I mentioned previously, the chronic lung disease pattern may simulate an old anterior anterolateral MI, wherein R is diminished all across the precordial leads and in the lateral leads 1 and AVL. And you get that right axis. So I showed that EKG, and I showed it's hard to tell. This EKG may be lung disease pattern, but may very well be an old anterolateral MI with poor precordial R progression and tiny R in the lateral limb leads and in the lateral lead V5. Okay. Another idea I mentioned yesterday in conjunction with the explanation about LVH I mentioned the differential diagnosis of poor R wave progression and how to sort out whether there is an MI or not. And you need to know the causes of poor R wave progression. Left anterior fascicular block, LVH, left bundle, COPD, and lead misplacement or proper lead placement, but the heart is too low compared to the lead, or the heart is too posterior compared to the lead. There is the flip side of that, which is big R wave. It's the opposite. It's the early transition. You have big R wave in lead V1, bigger than S, or those same ideas apply to big R wave in lead V2, bigger than S, the so-called early transition R wave. And you need to know the differential diagnosis whenever you see a big R wave. I mentioned that when you analyze the QRS, you look at four things. You look at the Q waves first, you look at QRS width, QRS height, and R wave transition in the precordial leads, including poor transition, poor precordial R wave progression, or early transition. So it's an important, whenever you analyze QRS, just follow systematically those four steps: Q wave, QRS width, QRS height, and the transition. And when you see big R wave in V1, this is a differential diagnosis. Could be RVH, in which case you'll have that associated right axis deviation. It could be right bundle branch block, QRS would be wide. It could be posterior wall infarction, in which case you will get a big R in V1 or V2, but it's also not just big, it tends to be wide, like a Q wave. An abnormal Q is not just deep, but it's wide. So you tend to have a wide R wave, more than one box in V1, V2. And sometimes if it is RS, R prime pattern with a posterior infarct, it will be wide initial R wave, more than one box, not just wide R prime. So it will be a special RS, R prime with a wide initial R. And frequently, unlike RVH and right bundle, when you have posterior wall infarction, the T wave is upright in leads V1, V2. It's not inverted. And frequently you will have, and you should think of doing posterior leads and see if you have Q waves in those posterior leads. The reason T is upright because posteriorly T will inverted as in an infarct. Another differential diagnosis is WPW with left accessory pathway. You need to know those very well, those four. The fifth one is less common. It's hypertrophic cardiomyopathy. Believe it or not, it's hypertrophic cardiomyopathy of the left ventricle. So you typically get big R wave in the leads V5, V6, and big S in V1, V2. But on occasion, that localized, very localized septal, basal hypertrophic cardiomyopathy, you may have big R in V1 and big Q in V5, V6 when it's very localized without much hypertrophy on the lateral and posterior or even anterolateral wall. Okay. Another entity is Duchenne muscle hypertrophy because it causes posterior wall fibrosis like a posterior MI. You need to know those. You cannot be a cardiologist and not know those basics, honestly. However, the most common cause of early transition, big R in V1 or V2, is just a normal variant. It is more common in young individuals where the heart is swung more anteriorly than older individuals. Older individuals may have poor R wave progression as a normal variant. Younger individual may have that early transition as a normal variant because their heart is swung more anteriorly. Also, that normal variant early R wave could be just low malposition of the electrodes V1, V2. Unlike poor R wave progression, the electrodes V1, V2 are too high compared to the heart. Early R wave progression, maybe V1, V2, are too close to the level of the heart. Those leads will see better the anterior depolarization, and you'll get that pronounced R wave in V1, V2. You need to print that and that, but especially this one, because most fellows don't know it. Also, when it is a normal variant early transition, the key is that you don't have other associated feature. No right bundle branch block, no abnormality of strain pattern of ST and T. no widening of the QRS. It's an isolated early transition. That's how you know it's a normal variant. Okay, I'll move on to this EKG. Can anybody tell me what's the diagnosis on this EKG? We have LVH by voltage criteria. You have the Sokolov and Lyons criteria. You have SNV1 plus R in V5 or V6 way over 35 millimeters, mainly met because of V5 and V6. You have the Cornell criteria, SNV3 plus R in AVL, it's way over 28 millimeters or 5.5 boxes. You also have the criterion of R in V5 or R in V6 more than 26 millimeters or 5 boxes. There is also a widened QRS with a right bundle branch block pattern in lead V1, but this is an unusual right bundle branch block. This is RS, R prime, S prime. Okay, RS, R prime, S prime, not the usual RS, R prime. So to call that fractured right bundle branch block is very suggestive of some myocardial disease. It's not your typical right bundle branch block. Fracture. The more notching and fracture in the QRS, the more you think of myocardial disease. What else in the QRS? What's the QRS axis here? QRS is negative in lead AVF and is negative in lead 1, but close to equiphasic. So you're negative in AVF, you're in this zone, and you're close to equiphasic to 1. So you're about here, you're close to minus 90 degrees. But you're a little negative in 1. So you're in reality in this northwest axis area. Does he have RVH? He has something unusual you don't often see on EKG. Okay, you told me he has LVH. Think about it. LVH gives you big S in the right precordial leads and big R in the left precordial leads. Well, look at this patient. He has a huge R in the left precordial lead, but he also has a huge S. Look at the S in lead V6 and V5. They are abutting each other and going all the way down. It's hard to tell where they finish. He doesn't have just big R. He has a huge S in the left precordial lead. And interestingly, the S in the right precordial lead is not that pronounced. You meet the Sokolov-Lyon criteria based on the size of the R in the left leads, not so much because of the S in the right leads. So what does this tell you? And you have a northwest axis, which I said LVH doesn't cause major axis shift by itself. Here you have a northwest axis. So what's the diagnosis?
Is it biventricular hypertrophy?
Yes, it's biventricular hypertrophy. It's massive biventricular hypertrophy. There are so many criteria for that. And there is one criterion I want you to know. In the mid to lateral precordial leads, when you have a huge biphasic QRS, a huge R and a huge S, with the summation of R and S, the whole QRS more than 50 millimeters, this is what we call, it has a name, Katz-Wachtel. It's a highly specific sign of biventricular hypertrophy. Plus, he has biatrial enlargement. You have a huge peaky P wave in lead 2, way more than 2.5 millimeters. And you have a peaky first positivity of P wave in V1 more than 1.5 millimeters. You also have deep negativity more than 1 millimeters. So he has biatrial enlargement based on V1, and he definitely has right atrial enlargement based on lead 2. So this is the final diagnosis. You have sinus rhythm, biatrial enlargement, right bundle branch block with a fractured RS, R prime, S prime pattern suggestive of myocardial disease, severe LVH voltage, but also RVH based on the unusual axis accompanying that LVH, whether you have right axis or northwest axis, that will be suggestive of RVH in conjunction with LVH. Also the Katz-Wachtel sign, that tall biphasic QRS in V4, V5, V6. And another hint, despite LVH, you're having small negative forces in V1. That's also suggestive of RVH in conjunction with LVH, that RVH is diminishing those negative forces in V1. Another thing is the strain pattern. So we have LVH strain here, but you also have ST depression in those leads, V2, V3, that is concordant with the QRS. That is not due to LVH, that LVH gives you ST depression opposite to the QRS. QRS is up, ST depression will be down. But here you have ST depression in those leads where there is dominant QRS negativity. This, in conjunction with everything else, is suggestive of RV straight pattern. So that also supports biventricular hypertrophy. So on this EKG, in the setting of LVH, RVH, and therefore biventricular hypertrophy is suggested by the axis, whether right or in this case northwest axis, the paradoxically small S and S prime in lead V1 discrepant with LVH, the ST depression in the right precordial lead, a form of right ventricular strain, marked by atrial enlargement, the fragmented right bundle branch block pattern, which indicates right heart pathology, and the Katz-Wachtel phenomenon, those tall biphasic precordial QRS complexes in V4, V6. This patient had moderately large VSD with biventricular failure clinically and biventricular enlargement on echo. And this is how we diagnose biventricular enlargement as from my book. You have any of those. One, voltage criteria for both LVH and RVH. This usually means you have tall R wave in V5, V6 of LVH with a small S wave in V1, paradoxically small S wave in V1, or R bigger than S in V1. R is not going to be large in V1 when you have biventricular hypertrophy because you have both ventricle pulling that R and S in different direction, but R is bigger than S, even though it's not that big, but it's still bigger than S. A second feature is LVH with right axis deviation, and that to me is the most common one. You have LVH that you have right axis or northwest, that's biventricular enlargement. Third is LVH with right atrial or biatrial enlargement. Fourth is LVH with T inversion in V1, V2, meaning a right heart strain pattern, which suggests biventricular hypertrophy. Although T inversion in V1 and V2 and ST depression in V1, V2 could be RV strain, but could also be anterior ischemia. So we have to analyze it in context. That concordant ST depression could be right heart strain or could be ischemia. In this EKG context, is clearly right heart strain, but in another context, it might be anterior ischemia. And the fifth feature is that tall R and tall S and mid or lateral precordial leads, the Katz-Wachtel sign. This is another EKG. What's the diagnosis on that EKG? So there is atrial flutter, agree. 3-to-1 atrial flutter, unusual atrial flutter. What else? Incomplete what? Right bundle? How come? Why right bundle? In order to call it right bundle, it's not enough to have RS R prime in V1. R prime should be pronounced, should be close in size to the S wave. And the slurred S in V5, V6 should be, by definition, wider than the initial R wave. So when the S is narrower or equal width to the R, this is not right bundle branch block. So analyze systematically. Go Q waves, QRS width, QRS height, and the transition zone. Those are the 4 steps. 1, there is no Q wave, abnormal Q wave. 2, how wide? It's about 110 milliseconds. It's not 3 boxes in any lead. Okay, wide. We'll have to define what type of bundle or non-specific intraventricular conduction delay. I don't think it's right bundle, like I explained to you. It's clearly also not left bundle. You don't have a slurring of the R wave on those lateral leads. So it could be a non-specific conduction delay. Another thing I want to tell you that in terms of a QRS width, when the QRS is between 110 and 120, and you don't have right or left bundle branch block criteria, it could be non-specific intraventricular conduction delay, but it may also be QRS widening from ventricular hypertrophy. So both RVH and LVH can give you QRS widening. I mentioned RVH can give you RSR prime pattern with a QRS 110 to 120 milliseconds. LVH can also give you QRS widening with progressive, incomplete, then complete left bundle branch block. But sometimes you have a mild QRS widening with LVH that is 110 to 120 milliseconds without loss of Q wave in leads V1 and AVL. So I would not call it LVH plus incomplete left bundle branch block. I would call it LVH with QRS widening. Anyway, do we have LVH voltage here? What is the Cornell here? SNV3 plus R in AVL is 20 millimeter, which fits the Cornell criteria for LVH in a woman. Or in a man, if he has big upright T wave in lead V1. It's hard to tell the T wave status in lead V1 here. I don't think it is more than 2 millimeters. In a man, the criteria are lower. You move to 12, 22. In women, 12, man, 22 millimeter if you have big upright T wave in lead V1. She doesn't actually. But she's a woman, so she fulfills the Cornell criteria. What else? So she has LVH. What else? You have LVH with right axis. It's simple. So to summarize it, this patient has atrial flutter, mostly 3-to-1 AV block. She has Cornell criteria for LVH based on SNV3 plus R and AVL about 20 millimeters. Her QRS is about 110 milliseconds, and it's likely QRS widening related to left ventricular hypertrophy. She also has a right axis deviation. So LVH with right axis deviation, inherently it's biventricular hypertrophy. There is also close to the Goldberger criteria I described earlier. Pronounced voltage in the precordial leads, reduced voltage in the limb leads. So it could be also suggestive of dilated cardiomyopathy. And this is what this patient had eventually, biventricular dilatation. This is a 75-year-old man with heart failure. What are the findings on this EKG? So you have inferior and anterior infarct, yes. So what's the diagnosis in this patient? Anterior and inferior MI? If you have an infarct from an LAD, especially mid-LAD, you get an apical infarct. Those are the patients where you get acutely diffuse ST elevation, and chronically you get diffuse Q waves. You get them in the anterior and in the inferior lead. It's an LAD that traps around the apex. So you get injury in all leads because the apex looks at all leads. So it could be that. When you see that EKG, one diagnosis should pop in your head. Yes, it could be MI, but there is something else. I'll tell you, okay, you think it's MI. Well, his echo shows normal EF and no segmental wall motion abnormality. Now, what's the diagnosis? Amyloidosis, yes. So let me summarize it here. So this patient has sinus rhythm with a long PR interval. He has low voltage in the limb leads, less than 5 millimeter QRS voltage in the limb leads, not quite low in the precordial leads. They are, to call them low in the precordial leads, they need to be less than 10 millimeters in all the leads. Not quite fulfilling that, but still relatively low voltage in the precordial leads. You have extensive Q waves in the inferior leads and in leads V1 through V4. So the possibilities are that he has ischemic cardiomyopathy and a prior anterior and inferior infarct. Usually the LV will dilate in those cases. You will get eccentric hypertrophy. You will get more pronounced voltage, except in end-stage cardiomyopathy with a lot of scar, you will lose voltage. However, whenever you see that infarct pattern with low voltage, think amyloidosis, because this is what amyloidosis lead to. Low voltage, especially the limb leads. You may not fulfill the low voltage criterion in the precordial leads, or low voltage that's progressively reduced over time. So it may not look low in absolute, but if you compare it to older EKGs, you'll see progressive decline in the QRS. And very importantly, you get pseudo Q waves in amyloidosis. So you can get extensive Q waves just because that amyloid tissue is replacing active myocardial cells. You're having electrically inert tissue in the myocardium, and that will cause Q wave. It's a tissue that doesn't have electrical activity. A truly low voltage in both precordial and limb lead is insensitive and is only seen in 30% of transthyretin amyloidosis to 50% of AL amyloidosis. However, the near universal finding in amyloidosis is QRS voltage that is not high. You cannot have LVH voltage, and QRS voltage is gradually decreased over time or is low in the limb leads. It fulfills the criteria of low voltage in the limb leads, or disproportionately low relatively to the LV thickness. So you see an LV thickness of 15, 16 millimeters, yet the QRS height is normal or somewhat reduced or bluntly low in the limb leads. So that's a hint for you. It's very important because, for example, this patient I showed here, I suspected when the echo came back showing normal EF, I suspected amyloidosis. So I did PYP scan, and the serum and urine immunofixation, those were negative. But we insisted on the diagnosis, and eventually we did endomyocardial biopsy, and that was the only way we established diagnosis in this patient. He had AL lambda type amyloidosis. Interestingly, even his septum wasn't thick initially. Normally, to suggest amyloidosis on echo, you want some thickening of the septum, typically 14 or above. His septum wasn't even thick initially. So that EKG was really the only hint to amyloidosis in this patient. His IV septum progressively thickened over time. This is another kind of similar case. 72-year-old man, heart failure, normal EF, that we admitted recently to the hospital. Again, low voltage. This time he's fulfilling low voltage in both the limb and the precordial leads. There are Q waves in the inferior leads. You see them in 2 and AVF. And there are extensive Q waves throughout all of the precordial leads. With this normal EF, this is very suggestive of amyloidosis. They show you that on board, you should think amyloidosis. So I did on this patient PYP scan and the immunofixation type of workup, all those came negative. So we ordered cardiac MRI and we're waiting for the result. If cardiac MRI shows diffuse subendocardial LGE, we might end up doing a biopsy, especially if he continues to have a progressive heart failure, to prove the diagnosis.